Hey everyone, welcome back to this episode of the Healing from Lyme Disease Summit. I'm Dr. Tom Moorcroft, and I'm so excited to be having this interview today and bringing to you a near dear friend, Shennon Delani, who is a medical doctor and an assistant professor of psychiatry at Columbia Medical Center. And as you know, the people that I like to bring in to talk about this are folks that are on the front line of treating patients with tick-borne illness, Lyme, Bartonella, Babesia, and all those other things. But also specifically, Shannon and I work together on a lot of, we share some patients, primarily focusing on PANS and PANDAS. And when we're looking at infection-induced autoimmune encephalitis, I think there's a lot of misconception out there. And that's why we really wanted to have this conversation today. And I think one of the cool parts is when I work with other people and I refer people out, I want to make sure that I'm sending you or your kiddo over to someone that I would trust to see someone in my own family or myself, but also someone who's diving so deep into the literature and has the clinical experience that when we work together, I'm learning new things. And so with Dr. Delani and I collaborating on a lot of different folks here, I've learned so many different things that I've been able to share with the physicians in our mentorship program, to share with my patients who may not be able to see her. And it's really been revolutionary to think about the way people with autoimmune encephalitis may be presenting and even metabolizing and using medications in a different way, say, than the standard population. And this is such a misunderstood kind of conversation. So Shannon, thanks for joining me. And I'm looking forward to a conversation about this.
Yeah, thanks for having me today, Tom. Great to be here.
Yeah. So, I mean, just kind of from a little bit of background, I mean, what gets someone into studying people with PANS and PANDAS and working with them? I mean, is there like some big old backstory here that really got you, passionate about this topic?
There is actually a little bit of a backstory. So during my intern year, I think it was back in 2009, it was right when the condition NMDA receptor antibody encephalitis was just being discovered. And what was really cool about that condition is that here we had a very specific autoimmune condition that had a very specific pathophysiology to it. And what was happening is that these patients typically were first presenting with psychiatric symptoms. So something like 70 to 80% of the patients who have NMDA receptor antibody encephalitis present with psychosis. So I was very intrigued that because most of the psychiatric conditions, as you know, we have no idea really about the underlying neurobiology to the disease. And so here's this condition where we specifically know that an autoantibody is targeting this NMDA receptor and producing psychiatric symptoms. So I was really interested in thinking, if we kind of understand this condition a bit better, we can understand psychiatric problems probably better. But then also it got me thinking, what if there is this huge cohort or subset of patients out there who have psychosis or schizophrenia, and their whole lives, they're told that they have schizophrenia and they're in a psychiatric hospital, and they actually may have this autoimmune disease, which would amount to a completely different treatment pathway instead of giving them traditional psychiatric meds. So I was very motivated when this condition was first discovered. And it is pretty fascinating that we're still learning about new medical conditions in this day and age. So I actually was very interested in so that was part of the thing that spurred my interest in research in this area. And then the other aspect was that from a clinical perspective, as psychiatrists in the field, whenever so during our training and residency and also during fellowship, what would happen is that when we worked in the hospitals, we would serve as the consult liaison doctors. So that somebody would come in with a complicated illness or potentially chronic illness, and they would get the $1 million workup and everything would come back negative. And the doctors often wouldn't know what to do with these patients because, they needed to help them in some way. And so typically at the very end, they would call in the psychiatrist to see the family or the patients. And you can imagine what the reaction is of the patient who's coming in with left-sided weakness, and now they have to talk to a psychiatrist about their problem. So the patients were never happy seeing the psychiatrist, but we would have to go as the psychiatric team and evaluate this patient. So I found myself both in residency and then in child psychiatry fellowship after hearing the patient's story, I would be very compelled, and I would, definitely think that there was some underlying medical cause going on, but oftentimes the attending psychiatrist would take more of a psychoanalytical approach to the problem.
Mhm.
And they would, sometimes it was honestly very ridiculous. They would say, oh, like that move from 7 years ago is definitely like contributing to why you're having these sudden onset, like new medical symptoms. So basically they would kind of diagnose a conversion disorder type illness and a patient who's having active medical symptoms, and it just was not logical to me. So I would get very frustrated with seeing that, and I felt like I was always on the side of the patients being like, no, there's a medical problem here, and we just don't have like the right answers, and we just, from a scientific perspective, there are so many unknowns, and that's why we need to do more research. So I think both of those things coming together, the discovery of NMDA receptor antibody encephalitis, and then my clinical experience that like made me very passionate to sort of find out better answers for this patient population, are the two things that motivated me.
Yeah, I mean, I think it's so interesting. It's so nice when you meet people who are really thinking about, hey, like, what is is there any identifiable medical condition underneath? Because it's like I always hate when it's like we're left over, just kind of like the fibromyalgia. We don't know. We'll just label you, and then just that's okay. And as you were talking, I'm like, wow, it's almost like leading the witness here. It's like, oh, so do you think it was that time in your life back then?
That's what it felt like for me also as the physician. It did not feel like a scientific approach to the problem. But I think in those circumstances, oftentimes the doctors who are taking care of these patients, it's very difficult for them to say, like, listen, I don't know what's going on. We don't have answers for you.
It's interesting as you say that. Like, I remember in residency, someone's like a family member said to me, "You are the first doctor ever to say I don't know."
Really?
And they're like, "We trust you. So what do we need to do next?" Right? It's like amazing, right? That we're taught to like be gods or something as if we know. But like you said, 2009, I mean, it's crazy that we're just discovering something like, I actually didn't know that. I thought that we'd known that for like since before I was born, because it's just like, to me, the NMDA receptor encephalitis, I'm like, just seems like so obvious now, but anyway.
But we've made so much progress in that domain. Now there's so many different autoantibodies that can cause autoimmune encephalitis, and they're discovering more every year, which is pretty fascinating. But yeah, that wasn't even a thing prior to that.
So with this, I mean, I think for a lot of folks watching, I think they're kind of going to be somewhat aware of PANDAS, right? And this sort of what I like to call toxin-induced autoimmune encephalitis, and many other people, especially I think Dr. Charles Ray Jones was the one who really told us like to step back from the label of pediatric acute onset neuropsychiatric syndrome and say, hey, look, it's an infection-induced autoimmune encephalitis or encephalopathy. But what, from a broader perspective, what is can you kind of like maybe generally define what this sort of autoimmune encephalitis type of thing is, just so people have a general understanding, and then maybe zero in on a little bit of what PANS and PANDAS is and how they may be similar or different? Because I think there's some nuances here that'll be really helpful for folks.
Well, I mean, I would love to kind of delve into some of those details. I mean, I wish honestly I understood the condition a little bit better. Traditionally, autoimmune encephalitis, like the one I was referring to in terms of NMDA receptor antibody encephalitis, typically presents with very significant neurological symptoms as well as psychiatric. I mentioned that their presenting symptoms are often psychiatric in the form of psychosis, but typically people who have straightforward autoimmune encephalitis will then develop seizures, and they'll have very profound neurological impairments. And so these are not subtle kind of findings. Like oftentimes as the illness progresses, they're so sick that they end up in the ICU. They're often, on ventilation and things like that. So, that's not an illness presentation that people can ignore or doctors can ignore, because
Right.
They need help, and all of their organs are problematic at that point. But the difficult thing with PANDAS is that most of the time, and we do see neurological symptoms associated, but most of the time we see primarily psychiatric symptoms that are presenting as the most problematic. So you can imagine that when we see a constellation of psychiatric symptoms, that a lot of doctors will start questioning the underlying diagnosis. So that's one of the most difficult things for, in my opinion, as a practitioner and a provider in this space, is sometimes dealing with other colleagues who basically delegitimize this illness because they look at these patients who present with new onset OCD or even psychosis or severe depression, suicidal ideation, even if they have underlying neurological problems like tics or other things like that, the doctors often just dismiss it and think everything is entirely psychological in origin.
I mean, I think that's a challenge because it's like it's almost like if it looks psychiatric, it must just be psychiatric, right? And it's like, so I mean, it sounds like the mainstream medical viewpoint is like it's got to be ultra severe neurologic, and otherwise it's kind of like, my frustration is always it's the all in your head situation, right? Or like with the food restriction, the acute food restriction that can happen with PANDAS. I mean, like we just chalk it up to anorexia, and you're like, I don't know. Hey, what do we do? I mean, like, how do you figure out the difference? And I mean, is there any diagnostic testing that actually can help in this arena, or are we just kind of left to try it out? Or
I mean, it is very frustrating. I mean, just to speak to that, I'll describe a negative interaction that I had with a colleague just yesterday, about a patient that has a 12-year-old patient of mine who has a clear-cut history of Lyme disease in the past, presenting with numerous PANS type symptoms over the course of his illness. And he presented with mania, emotional dysregulation, severe OCD, tics. So this is kind of a classic patient that I will see, who also has a history of Lyme disease. And throughout the years, he had sort of discoordinated care where he went to a lot of different doctors. So he briefly got some IVIG, briefly got antibiotic treatment, had some plasmapheresis. And one of his doctors was concerned enough in the last week to tell them to go to the emergency room, which unfortunately, as you know, probably as a physician, that can be one of the worst places for patients to go to get help, even though you think that it should be one of the best places. So this doctor ends up calling me up on my cell phone, basically to express his opinion that he felt as if this kid, he said he was appalled and outraged by the treatment that this kid was getting. He said it was a disservice to the kid and his family. And so I started talking to him a bit more. And, this, like I mentioned, this kid had received IVIG and plasmapheresis. And so I explained to him that in terms of treatment guidelines, when it comes to PANDAS, if you encounter somebody who has severe, moderate, or severe disease, that the guidelines specifically say that immunomodulatory treatment is part of the treatment plan. And I explained to him that the consortium of doctors who are experts from multiple different disciplines have come together from multiple different institutions throughout the US to develop these guidelines. And he wasn't really willing to have a conversation with me. And in fact, he heard that and he said that these doctors are whack jobs, quote unquote. So it was a very difficult conversation to have because he was just calling me to kind of, just give me all of these negative opinions. And there was no like two-sided conversation to be had at that point. And it was frustrating because the parents had reached out to me asking me about what testing that I would recommend because this kid was going to undergo a lumbar puncture. And so I made the typical recommendations in terms of comprehensive Lyme disease testing and Bartonella testing. and testing for autoimmune encephalitis panel and everything that we would normally do for a kid who's presenting with very severe neuropsychiatric symptoms. And then during the conversation, the doctor told me that he absolutely refused to do any of the Lyme disease testing because that's not what this kid has. And the only thing he would test for was, because this child was on Rituxan, he would check to make sure that he doesn't have a fungal infection because of the medication that he's on, but he refused to do any Lyme testing. So it's just incredibly sad from my perspective and quite frustrating, because here's this family in complete crisis. And over the course of years, they've been to multiple different doctors. Nothing has really helped properly. And it's a very difficult area for parents to navigate. And so then they're caught between these two systems. They come to me and ask for advice, and I tell them what I think needs to happen. And then they encounter this pediatric neurologist in the emergency room who's basically saying that all of these problems are psychological and there's no reason to even do a comprehensive medical workup.
I mean, the frustration that I'm sure so many people listening have, and I certainly have, I'm just taking a lot of deep breaths over here, because I feel as we've talked in the past with a lot of people we work with, I mean, the medical community seems so closed-minded. But what I hear you saying is you're doing all the standard medical stuff. And because there's other new emerging research, which really isn't all that we're learning more, but just to step back, the PANDAS working group is not like a bunch of schmucks in their basement. I mean, this is Sue Sweeto's at the National Institute of Mental Health, pediatric department. There's people from Yale, Mass General, Boston Children's, all these hospitals in Minnesota, all these places in California. These are big name, well-respected researchers. I mean, Jim Leckman's on there. I mean, these are not asses. And these are not people whose credentials are being called into question. In fact, these are people who stand up at conferences and somebody says, oh no, that's not the way it is. And they're like, oh, really? Have you looked at the research? Let me just rattle off 90 billion. Sue Sweeto puts people in their place because they're so closed-minded. And when I'm seeing a patient, I don't want to have that conversation. I think it's okay at a medical conference for doctors to debate. That's one of the places we should debate. But when you're saying, hey, I want to do all the right medical workup, and also let's be open to this other possibility and just evaluate it, what's the problem with getting a test? Because if the test is negative, great. But what if it's positive? And that's the scary part. They're closed off to that,
I felt like it was one thing for him to call me and just spew his opinions, despite me not even asking for them. But to be so closed-minded as to say, no, I'm not doing a test for this kid who's presenting, the sick kid who's presenting in front of him, is just I have such a difficult time with that.
Well, and I think I'm sad, because wouldn't you prefer it to be a treatable cause? I mean, this is the thing I never understand. It's why? And the other part of it is, if you're an egomaniac doctor, which there are a few of us out there, I may or may not be one of them. I hope not. But why wouldn't you just say, hey, I'm going to get the testing and prove you wrong, rather than go, oh, let's screw this. Why wouldn't you be curious? I mean, I think I've heard you talk about that a lot in the past. It's it's the curiosity. And I'm so depressed, not really depressed, but I'm a little frustrated with the system that you and I work in, that curiosity is kind of out the window. Isn't that why we got into this? We wanted to help people get better.
That's what I thought. But I think he was sort of thinking that he was taking the moral high ground, because he started talking about doctors in private practice who don't accept insurance and describing them as predatory, and basically saying that any of the doctors who prescribed these treatments to this kid were acting in a predatory fashion. And so, it's his job to sort of correct all of this.
Huh. Yeah, it's a shame. I mean, I think that collaboration and stepping back to say, hey, are we doing the right thing? But it was I never heard you say not doing it. And I think that that's what people misunderstand about a lot of us, is for me, if I were in the system, because I'm sure that if, they were talking about me, I'd end up in lumped in that category. But it's we're not given enough time to see patients. We're not being reimbursed for our time. The patients aren't getting their stuff covered. And all we're trying to do is get them better. And the number of kids I see, like I have a kid who was doing exceptionally well. She, basically her PANS onset, was hallucination and, suicidal ideation, had been in the hospital after multiple suicide attempts. We started working together. She was doing great. All of a sudden, no more hospital visits, no more suicidal ideation, the whole 9 yards. But it was like 12 or 14 months later, the family just had a lot of things going on and they kind of fell off the wagon with treatment. And next thing you know, the kid's trying to kill herself again. She's back in the ER. I talked to the doctor there and they're like, oh, because I got a copy of their note. They're like, Dr. Morkov said they were previously treated. There's nothing more to do. It's psychiatric, which is totally not what the conversation was. Wow. And as of this conversation right now, today, this kid's been in a psych hospital for 2.5 months and she's 14.
Wow.
And I'm like, could you just try a little bit of antibiotic therapy or maybe call me one more time and be clear? Because it's like, I don't understand how it's appropriate to leave a child in a psych hospital. And the other problem, and so maybe, because I mean, it's nice to have a rant, I think, about these things, because so if people know that it's not just the patients who are getting shit on, it's us too. And the people who are willing to do this work. And I do think there's probably predatory people, but I'll tell you, if how many people just tell you to get vaccinated for no reason? And they don't know why. They just were told this, so they spoon feed it to you, or get your Lipitor or whatever. So, I mean, this happens on all sides, right? I mean, do we really need a colonoscopy every 25 minutes? Probably not. So, but I think more importantly is like, I should have not distracted myself, but
exactly. What area of the body are we on now?
Yeah, right.
Or
I think it's the heart, and that's the part the doctors are missing. I mean, I think we're afraid to say we don't know, but we're open to working on it. I mean, when we look at these people though, like I just, feel like we need to step back and give them an opportunity to heal, whatever that is. So if you're seeing a kid with PANS, what are kind of the general treatment approaches? Because I think one of the things at the other side, which I can't even believe we take sides in medicine, but think is that we're withholding certain treatments in lieu of others. But I mean, like, if you were to look at a person with PANS, what are the kind of general categories of treatments they might expect to kind of have considered, even like not even that they need, but like, are there groups of treatments that you might consider offering them or evaluating them for?
Well, to be honest, I think that patients with PANS, you have to have a very individualized approach with each patient, because even though it can be a similar constellation of symptoms, oftentimes I see very different like treatment algorithms working for different people. And the frustrating thing when you're a provider trying to tease apart like what's actually happening with PANS also is that it can be triggered by a lot of different infectious triggers, like we know. So a PANS that's triggered by mycoplasma or strep can look very different than one that is triggered by Lyme disease and Bartonella, in my experience. Mm-hmm. So I think number one thing to do and approach that I have is to do a very comprehensive like initial evaluation, which involves getting a lot of laboratory data, because I think a combination of getting a very comprehensive clinical history and combining that with the laboratory data does really, you can go quite far in having a very thorough initial appointment. But I've seen kids that who are diagnosed fairly early with PANS and can be put on a combination of, let's say, a few months of antibiotics and vitamin D and fish oil and probiotics and do quite well and never have to go on antibiotics again. I can see others that have a history of Lyme disease, for example, and maybe just got the initial treatment in the beginning and then had their initial sort of PANS presentation maybe months or years down the road. And once it becomes a chronic illness, that can be very, very difficult to treat in my experience. But so again, I can't say that I have a typical approach. because I've seen patients, there's such an individualized response to antibiotics as well with patients. But I will say that a combination of antibiotics, herbs, and for very severe patients, immunomodulatory treatments have been the most effective, like on the whole. I don't know what your experience is.
Yeah, I mean, I feel the same way. It's like, I mean, I think we need to look at we need to look at the triggers, and one of the things that I found too that's so interesting is the infections are typically the initial trigger, which leads to the autoimmunity and that inflammation. But the other side of it is later on, other things re-trigger people, so once that inflammation is set up. And so I see a lot of stressful events re-trigger PANDAS. But I personally, at the moment that we're talking, don't believe that that was the trigger, like the initiating event. But it's like always interesting because people are looking for that acute trigger, and they're like, well, they didn't have acute onset. I'm like, somebody's like, well, I talked to a patient the other day. It's like there wasn't really an acute onset. I mean, I don't know. There was like, for a month or two, I just had some tics that I never had before. And then I had this. I'm like, well, didn't the tics start out of the blue? They're like, yeah. I'm like, well, that's acute, so it's kind of funny. Yeah, it's one of those things, that when you talk about the immune modulatory stuff, this is one of the things that I think is really interesting too. Some of the research try to look at like IVIG, like right up front, or a single dose. And then there's a bunch of practitioners who are doing 6, 12, 24 doses. I mean, have you seen any trends in our immune modulatory treatments, in their efficacy? Because I know there's some studies that show variety of efficacy. Does the timing of when the kid gets treatment make a difference?
Yeah, I wish that I had, as clinical data can be so complicated because each patient is kind of coming in with their own story, and they often, from a tick-borne illness standpoint, people are often co-infected also. It's typically, I don't just see someone coming in with a history of Lyme disease. It's often Lyme disease and Bartonella, or Lyme and Babesia. So it's very hard for me to know as the clinician sort of what's exactly triggering what, and what are we dealing with kind of in the moment. So that one's a kind of a hard one for me to answer.
Yeah, I mean, and this is fun for me because I love having real conversations, not the one where you talk to the person, hey, everybody needs IVIG. They need 12 to 24 doses and they need 3 antibiotics for 4 years and they'll be fine. Like, that's bullshit. Yeah. Like, so guys, everyone, we're having like the real conversation that people should be having with you. And I know in some other interviews, we've talked about things like informed consent. These are the conversations you should be really having with your practitioner. Anybody who tells you they've got PANDAS figured out, got Lyme figured out, they're full of crap. Now, a lot of us have a very structured approach, and I think that's really important to understand. It's not like we're flying by the seat of our pants or we're just making crap up, but we're really trying to be honest with you that the stuff that you're unsure of in your own symptoms is the same stuff that we're unsure of. Now, we have a lot of data to support what we're doing and a lot of experience, but we're really in the summit here trying to have like real conversations about the challenges. And this is also, I mean, because I don't want to diss all of our colleagues. A lot of them, we are raised in a system where if we don't know, that's kind of like not acceptable. And so to me, I love not knowing, because that means we can learn more and we can help you even more than we could yesterday if I'm open to that. So and I guess, Shannon, one of the questions too is, do these kids with PANS and PANDAS, I mean, are they, so like, let's say that, because I've never heard or seen you withhold psychiatric therapies and treatments just because you're like, oh, you just have Bartonella, just treat it with azithromycin or rifampin. It's like, it's kind of that combination treatment of everything that whole person needs. But if you were looking specifically at a child with PANS, are they, and this is kind of, I think the thought I lost a minute ago when I was getting all riled up. The one thing that really strikes me is, I guess I'll ask you the question first before I finish the thought. Do these kids respond the same way to typical psychiatric medications if you have PANS or PANS versus sort of the general population?
Yeah, I think that's an important question. So it sort of, again, depends on the patient, but the classic PANS patient that comes to me often is one who has been down the psychiatric road and maybe has been admitted to the psychiatric hospital a couple of times because of the severity of their symptoms. They've often been tried on psychiatric medications, sometimes from every single class, and numerous psychiatric meds from every class. And oftentimes their illness is just intractable. It's not as if these psychiatric medications are helping. They often make the situation a lot worse. So when I approach a patient, it kind of depends. If they've tried every single SSRI and every single antipsychotic medication and other things to help treat their OCD and just nothing has worked, and they're presenting with a history of infections, then I think I would be a lot more leery to trying another psychiatric medication for the 14th time if they haven't really worked before. That being said, if someone is coming to me and they have a history of Lyme disease and like significant OCD, will I try a psychiatric medication at a very, very low dose and go up very slowly? I probably will. So it sort of depends on the history, but in general, these patients, especially the serotonergic medications in the Lyme disease population and also kind of the PANDAS population, they can be extra sensitive to those types of medications. So for that reason, I usually rarely will prescribe an SSRI for a kid who has a strong history of Lyme disease and PANS, because I've tried it numerous times, even at very tiny doses. And sometimes within 24 hours, it can induce suicidal ideation or make these kids very agitated or more anxious. It does not have a calming effect on these kids. So I typically like to go to medications that are more calming and kind of mood stabilizing. I think we've shared a few patients before in the past, so you know that I really like the medication lamotrigine. And I still start that at low doses and go up slowly, but it's a medication that is generally well tolerated in this population. And I don't see the extreme like emotional dysregulation that I can sometimes see with the SSRI medications. So it is important to consider psychiatric medications in this population. I think you just have to be somewhat thoughtful about it. And sometimes, interestingly, the medications that aren't typically deemed psychiatric, like, for example, the beta blockers, propranolol, and other medications such as that can actually help some of the psychiatric symptoms, even though it's not something that we would typically think to prescribe as a psychiatrist.
Yeah, I think that's one of the things that's always struck me about this population is when the typical meds don't work, why do we keep saying it's, because like even if I have someone with a conversion disorder, I can pretty much squash their mood pretty easily. There's a lot of drugs that I can give them, but it's like I feel like even like a lot of the benzodiazepines, people respond they have a very weird response to them. And and that's what I was kind of thinking about this particular person that I mentioned earlier. It's been several months and they still can't control hallucinations, where we were able to control them quite easily with a little bit of medication and transition to herbals. And it was like, so I'm not saying like, I feel the same way, like don't not offer it. But when you have a response that's unexpected, maybe you should look a little deeper and go, oh, because when I look at the diagnostic criteria of PANS, there's no lab work that says you have PANS like that. There's just nothing there. It's all clinical. But I know that there's some work on these autoimmune, these antineuronal antibodies. But maybe it's like the NMDA receptor encephalitis that maybe when we have a little better technology or we think about it a little differently in 5, 10, 20 years, we'll actually have a diagnostic lab test. And we'll be able to go back to all this blood, because I know we talk a lot about Borrelia miyamotoi, because like I published 4 of the first 24 cases in the country, which are amongst the first 73 human infections published in the world. And it was like crazy. Within the year or, after that, they went back and looked at stored blood from 2014 back to 1992. And they found like 320 other cases where they presented with Lyme-like symptoms, but it wasn't Lyme. And we just told them they were crazy. And it was in their head. Yet when we learned more later on, when we became more curious, we went back to become curious. It's kind of funny. we found out, oh, you actually had Borrelia miyamotoi. And then we all published these papers like, oh, we found Borrelia miyamotoi. I'm like, but you're the same exact doctors who diagnosed these people with being crazy.
Mm-hmm.
So anyway, I mean, I just think it's important to think that way,
Yeah, it's an interesting intersection for me, because I went into psychiatry because, to me, there was such a world ahead in terms of an entire frontier that we just don't know about, and exploring the brain and how it works and how it causes psychiatric problems and influences behavior and things like that. To me, that's just completely fascinating. And psychiatry is like in its infancy, because we know very little about what causes psychiatric conditions. But it's an interesting confluence of also working in the realm of tick-borne illness, because it's another area in which I feel like doctors and the medical profession is just like, we know so very little about this problem that is truly an epidemic at this point. And also fascinating that we're still discovering new tick-borne illnesses, since you mentioned Borrelia miyamotoi. That was first human cases, I think, in the Northeast were identified in 2013. It's just a few years ago.
It's pretty wild. So I just think that it's so fascinating, and I really appreciate your willingness to come and have a real conversation. I think if we could have more real conversations, because I heard nothing, but I just, I was a little frustrated because we weren't open to the possibilities for the child. Not, and I love the folks who have come together for this summit, because none of us are going, hey, by the way, like I was right and they were wrong. It was like, I wanted to work together with the other practitioners to make sure that we were doing the right thing for the kiddo. And I really think that it's been an honor to be able to work with you on these cases, because we've been able to make progress where other people haven't. And it's not that I did it by myself, but in partnership, we've been able to unlock the Rubik's Cube. It's funny. It's like my buddy just we went out skiing for a couple of days when he came out for a little retreat we did, and he brought his kid, and his kid's doing this Rubik's Cube thing, like 1,000,000 miles an hour. Right. And I'm like, I've never solved the Rubik's Cube, because I kind of, like, when I was younger, I gave up. Right. I'm like too complicated. And then he says, oh, just watch this guy's video.
I pegged you as the type of guy who's doing that every night.
Yeah. Right. But it's like, but when you learn, but what was interesting was this he's now 17. I've known him for a few years, but he just goes, here, you do this, and this, and this, and this. And I was like, yeah, no. And he's like, I learned it from this one video. Just go look. And
Wow.
I followed the thing. And even though I followed the instructions, I still made mistakes, even though I was just pausing it. But what was really cool was when I started to see it unfold, I got more excited and more curious. And then you can see the people who dive down that rabbit hole of doing it, learning how to put things together. But if you make one wrong turn, you have to start all over. And so I think together as a community, this village that is working on patients like this, we can minimize the wrong turns. And that's why, like, when I send patients, like, I want a Lyme literate cardiologist, a Lyme literate neurologist, a Lyme literate dentist, and a Lyme literate librarian. I'm like, you don't need that. What you need is someone to make sure we're not missing something, and I haven't put on the tunnel vision, And I just think it's, I'm open to other diagnoses, as I know you are. But when I see a patient who's been treated by everybody and nothing's working, and you're telling me I'm wrong, but you have nothing else to offer, I'm like, that's kind of a little blasé, you're like, so I appreciate this opportunity, today to have this conversation, because I think a lot of people need to know that you're not, none of Shannon and I don't want you guys to be out there experiencing this medical gaslighting and this invalidation and all the trauma that comes along with them not believing you. But, and it's different for us than you, but we're still fighting that fight too, where, there's so much closed mindedness, and we should really be open to curiosity. So, I just really appreciate the opportunity to have this conversation that's like real and raw rather than fluff and BS, because this is what moves the needle forward for our patients.
Thank you. Yeah, I totally feel the same. It's
Yeah.
nice. Sometimes as a doctor in this field, it sometimes feels like we have so many more questions than we have answers. And it's nice to have close colleagues who are all working together, and we're trying to solve this for our patients as well.
Yeah. Well, again, thank you. It's an honor to chat. I always love talking and, love being able to work on patients together because it opens my eyes to things that I might have been missing. And I just hope that everyone listening, I know there's so many practitioners listening, keep your eyes open. It doesn't mean throw out your differential diagnosis and throw out regular medicine. It's just like, look at the possibilities and then figure out what's best for that unique individual in front of you. And I hope that really, Dr. Delani's experience and, my little bit of crazy commentary can help you kind of remember to bring that together, right? We want the best of everything. And it's just like, be open to possibility. And as a patient, advocate, there are PANDAS guidelines. I'll make sure that we get those into our show notes, like, our Summit resource page for you, because those guidelines that Dr. Delani mentioned are just so critical, because I feel like it's really nice to talk about the emotional side of things and be human about this. And there's also a lot of science behind what we're doing. And I actually remember, I'm the worst at closing an interview because I always think of something new, but I was talking to Jim Leckman at one of these Connecticut PANDAS advisory councils way back in the day. And we talked about a paper that showed that IVIG really didn't help that much in PANDAS. And they were trying to figure out why. And then within 12 months, another much more robust study that involved more people and had more data points that allowed us to pull out who it's good for and not came out. And next time we're talking, it's like, oh, we have more information. And to me, that's exciting. The next day, what I knew last week may be different. The truth is ever evolving. So thanks for reminding us of that.
Yeah, of course. Thanks for having me.
Yeah. So everyone, thanks so much for joining us for another episode of the Healing from Lyme Disease Summit. I'm Dr. Tom Moorcroft, and I hope you found a lot of value in this and inspiration. Definitely look Dr. Delani up. She's amazing and love working with her, and I know you will too. And until next time, we'll see you in the next episode.